Hello, everyone. My name is Dr. Ashok Agarwal, and I will be your host for the next 2.5 hours. And we are here to welcome you to the next online ART training in Module 5A, which is Overview of IVF and ICSI. Today is Tuesday, May 18, 2021. And this program is made possible by the American Center for Reproductive Medicine at Cleveland Clinic. Again, welcome to everyone. So here we go. This is my short biography. Um, for those who have not attended the previous program, I'm the Director of Andrology at Cleveland Clinic within the Department of Urology. I'm also the Director of Research and very much involved in research in the causes of male infertility. So our program is one of the most active programs looking at the research, focusing our research on causes of male infertility, looking at how we can find solutions that can benefit patients who have male factor infertility. The organizers and the speakers have no conflict of interest. No companies or outside entities were contacted for sponsorship of these events. This program was made entirely possible by the educational support by the American Center for Reproductive Medicine, and the webcasting was supported by David Reichling, David Wolfley from our Information Technology Division at Cleveland Clinic. Thank you to them. The course faculty who you will be hearing today have donated their time for this online training course. Program coordinators you will meet here have volunteered their time for this training. The names, images, and description of products and instruments that you may see in the lectures are used routinely in various laboratories, IVF labs, and these items are not endorsed by the speakers. So today's program, as you have seen, this is called Module 5A, which is basically an overview of in vitro fertilization and intracytoplasmic sperm injection. The program is supposed to complete by noon because it includes the part related to multiple choice. Our lecture component should finish within 2 hours. We have timed it. So the learning objectives today is talks related to essential equipment, supplies, and culture media, protocols for oocyte retrieval, oocyte denudation, and embryo transfer, oocyte characteristics and embryo quality assessment, and important parameters for embryo culture, monitoring, and quality control. In addition, we have two more lectures, one by Professor Hassan Salam and one by Kelly Athaije Virka. So these are the components of the today's program that you will see starting from in a circle, starting from equipment to oocyte retrieval, gamete quality, embryo culture, expert commentary, and then industry perspective, and a very brief conclusion. A very innovative part of these talks. These are various issues that they have experienced over the years, and they have illustrated them in a way so that they can provide solutions to the questions that many of you will have. So these talks have taken very long periods of time, and I will tell you towards the end. So this is our next speaker, and which is Dr. Christina, and she has already been introduced, and she will be speaking on gamete quality and embryo selection strategies. So let me begin her presentation. This is a recorded presentation, but Dr. Christina is present today.
Hello everyone, my name is Christina Anagnostopoulou. I'm a senior clinical embryologist, and this is a presentation about gamete quality and embryo selection strategies. The learning objectives include to understand why is it important to create oocytes and embryos, to be able to identify oocyte maturity stages, to learn oocyte characteristics and abnormalities, to learn how to classify embryos according to conventional morphological criteria, and finally to introduce morphokinetic parameters based on time-lapse observations. So first of all, why is it important to create oocytes and embryos? It is well documented that embryo quality depends mainly on oocyte quality and maturity. It is important for the embryologist to be able to distinguish between different maturation stages in order to plan the time of IVF and ICSI. If we can do embryo morphology assessment, we have a good prognostic tool in order to identify which of the embryos will further develop and will have the highest implantation potential. So we can achieve a higher implantation rate, reduce the number of embryos transferred, even go to single embryo transfer, while at the same time reducing multiple pregnancies. Even at the time of the oocyte collection, the embryologist is able to estimate the oocyte maturity by the cumulus expansion, appearance, amount of cumulus, coron expansion, appearance, and oocyte appearance. In this image, we can observe an M2 oocyte surrounded by the coronal cells. The coronal cells are still opposed to the oocyte, but they are radiating, and the cumulus cells will look like a fluffy mass that is easily stretched. In this image on the right, we can observe another mature oocyte on a higher magnification. In this image, we can observe an immature oocyte at the germinal vesicle stage. We can see the differences with the expanded cumulus oocyte complex. Here, the cells will be tightly attached to the oocyte. It will look more dark and more difficult to observe in the follicular fluid. In the majority of expanded cumulus oocyte complexes, the oocytes will be mature at the metaphase 2 stage. However, we can only confirm this fact after oocyte denudation in order to remove all of the cells and observe the presence of the first polar body. So this is what we would see after oocyte denudation. It is very easy to identify, to distinguish the immature oocyte at the germinal vesicle stage because of the presence of a clear nucleus here. It is also more dark. This is the next maturation stage, metaphase 1, with no nucleus and no polar body. And finally, this is a mature oocyte with one polar body. The second polar body will be extruded after fertilization. Many studies have been conducted showing that the injection of immature oocytes leads to poor clinical outcomes and high aneuploidy rates. In addition, whenever there is an increased proportion of immature oocytes, this has been associated with reduced fertilization rate for the remaining mature oocytes. However, in some cases, a couple will have only a few mature oocytes and may benefit from the use of all available oocytes. So in this case, we prefer to in vitro mature oocyte and inject them a few hours later instead of directly injecting the immature oocytes that most probably will lead to aneuploidies. In this slide, we can observe some abnormalities of size and shape. For example, here is a giant oocyte, almost double the size of a normal oocyte, and most probably diploid. This is an abnormal shape oocyte. And here we see a rare finding of two oocytes enclosed in one zona pellucida. More morphological abnormalities of the cytoplasm is the centrally located granulation of the cytoplasm, the refractory bodies. The vacuoles are fluid-filled structures that may have not biological difference if they are small, but if they are bigger than 14 micrometers, probably they will affect fertilization rate. In these two images, we can observe the smooth endoplasmic reticulum clusters that have been associated with poor fertilization rate and the presence of aneuploidies. Some extracytoplasmic abnormalities include the dysmorphic zona pellucida, the abnormal shape of the egg, The large perivitelline space may be the outcome of a post-mature oocyte, so the oocyte has shrunk, so that is why the perivitelline space looks so large. Also here we see the debris in the perivitelline space. The first polar body should be round, intact, and single. In cases of very big polar bodies or multiple polar bodies, the oocyte has a very poor prognosis. This is a very important step of IVF. It is the fertilization check. It should be done 16 to 18 hours post-fertilization. After that time, the PNs will fade and it will be not possible to do fertilization check. So we should observe normally fertilized oocytes with 2 pronuclei, 1 male, 1 female, and 2 polar bodies. Non-fertilized oocytes show no signs of fertilization, no PNs, and abnormally fertilized oocytes show 1, 3, or multiple pronuclei. In the case of 1 PNs, we can keep them for assessment later. In the case of 3 PNs, it is maybe better to keep them separately or even discard them. This is one of the earliest grading system for zygote scoring from Tezarek and Scott. It is optional, however, if you do it in your clinic, you can combine it with cleavage states and Blastocyst stage assessment, and in order to improve embryo selection. According to this system, the pronuclei should be of similar size, they should be located in the center of the zygote, they should merge, the nucleoli should be aligned, and there should be a similar size and number of nucleoli. So according to this grading system, this is the best option with all the nucleoli aligned, and those are some of the worst scenarios with the pronuclei far apart or of a different size. Those are some additional criteria for zygote scoring: granularity of the cytoplasm, organelle clustering, presence of vacuums, areas of necrosis, and abnormal shape of the egg. All of these are markers of poor oocyte quality. However, this is a positive marker. The cytoplasmic halo, which is present in most of the zygotes, it probably indicates active metabolism. In addition, early cleavage, it is also optional, but in case that you are doing it and you observe it 24 to 26 hours post-fertilization, it is a sign of fast development. On day 2 and 3, probably the most important marker is the number of cells, and it is predictive of the implantation potential. Delays in reaching the 4-cell stage result in poor development. However, too rapid cleavage is also predictive of lower blastocyst formation. So on day 2, it is best to observe 2 to 4 cells. 4 is an ideal number for day 2. And on day 3, we should observe at least 5, so we are beyond 4-cell stage, and ideally 8 cells on day 3. The degree and pattern of fragments has been associated with embryo implantation potential. Fragments are small pieces of cytoplasm that are not included in the blastomers. They do not contain a nucleus, and it is not very clear how they have been created or how much they affect embryo quality, because they tend to get reabsorbed, and there are many self-correction mechanisms. However, in most grading systems, we would grade as optimal the embryos that have blastomers of equal size and very few fragments. And as the fragments increase, we consider that these embryos are of lower quality. For example, in these 3 images, this embryo would grade it as 2-cell grade 2 because there are some fragments here. This is a 4-cells grade 1 embryo, no fragments, equal blastomers. And this is a 7-cells embryo, grade 2, no fragments but an equal size of blastomers. Further grading we can do on cleavage stage is according to the pattern of fermentation, the presence of vacuoles, the thickness of zona pellucida. This is a problem we can overcome with assisted hatching, multinucleation, and synchrony between cells. So cells should be going from 2 to 4, 8 cells, dividing synchronically. on more states on day 4, it is probably more difficult to do embryo quality assessment because there are more cells. Tight junctions and desmosomes begin to form between the cells, so it is more difficult to identify them. And compaction starts, and at the end of day 4, we have the beginning of blastocyst formation. So this is also an optional step. On the contrary, on day 5, there is a very well described grading system from Gardner and Schoolcraft. The grading is done according to the degree of expansion and hatching status. So we would grade as 1 the early blastocyst when the cavity occupies less than half of the volume of the embryo. Gradually, this cavity increases in size, and on the expanded blastocyst, then the volume of the blastocyst is larger than that of the embryo. The zona starts to thin, and then we have the hatching and hatched blastocyst. Also, we grade blastocysts according to the quality of the inner cell mass and the trophectoderm from A to C, A for many cells and B or C for several or few cells. So in this slide, we can observe some of the early blastocysts. The blastocyst, the cavity is very small. It just starts to get formed. Those are some expanded blastocysts. The volume is now larger and the zona is thinning. We observe here many cells in the inner cell mass and many trophectoderm cells, so we would grade this as 4AA. Those are some hatching blastocysts. We see that the trophectoderm cells start to herniate through the zona. Those are probably result of assisted hatching. And if we should grade further our blastocysts, this is a 5BA, 5 because the cells are already herniating through the zona. This is a 2BB, it is grade 2 because the cavity is almost half of the volume of the embryo here. And this is a 2BC, it is graded as C because the trophectoderm cells are very poor and poor quality and few number of cells. There exist other grading systems for embryo selection, such as morphokinetics, transcriptomics, proteomics, metabolomics, and oxygen consumption. All of these are non-invasive techniques. Also, we have the option to do pre-implantation genetic testing after embryo biopsy. That is, of course, an invasive technique. All of this can be combined with morphological criteria to improve embryo selection. During this presentation, we can discuss more about morphokinetic observations. So what we can observe more if we have a time-lapse system that monitors continuously the embryos. So we can observe the exact timing of fertilization, of divisions, the synchrony between the cells, the history of fragmentation, whether there is multinucleations. There are multinucleations. We can identify specific features with the software using artificial intelligence. So maybe there are some features that we cannot identify with our own eyes. And probably a hope for the future to combine all this data in order to develop a universal algorithm to improve embryo selection. And those are some of the critical morphokinetic parameters, the time from insemination to PN fading, to the division to the 2, 3, 4 number of cells, the duration of the second and third cell cycle, and finally the timing to the initiation of blastulation and formation of a full blastocyst. There are many studies supporting the time-lapse predicted value using results from pre-implantation genetic testing and showing that chromosomally normal embryos display strict and tightly clustered cell cycle parameters and that only a few unemployed embryos will exhibit normal values. And also there are studies providing us with algorithms that have been produced just by morphokinetic parameters and using just the exact timing of divisions up to the 4 cell stage and non-morphological evaluations. However, there are also studies that do not confirm the time-lapse predictive value, that have not achieved to find a correlation between morphogenetic parameters and aneuploidy. There are meta-analyses that also claim that there is insufficient evidence to support that the time-lapse system is superior to conventional approaches. So in case that you are using time-lapse, it is important to be aware of the fact that there is no proof that it gives us an advantage. However, it can provide us with a lot of information that we can use to improve embryo selection. So let's see some of these observations. One is the direct cleavage. Whenever the cell cycle from 2 to 3 cells is less than 5 hours, it is very fast. For example, this is an example that the embryo goes from one cell to 4 cells directly. So these embryos most probably show a lower implantation potential. Another observation is the reverse cleavage. If we are just using a traditional incubator and take the embryo out at this stage, we can see 2 cells. However, if we progress the video, we can see that it goes back to 1 cell. This is called the reverse cleavage, and it can be observed with the time-lapse system. The presence of 2 or more interface nuclei within a single blastomer may affect embryo quality, and it is called multinucleation. For example, in this image, we can observe a multinucleated 4-cell stage embryo, and in this image, we can observe a multinucleated 2-cell stage embryo. In this video, we can observe blastocyst collapse. In some cases, we can see a blastocyst form increasing in size, expanding, and then collapsing again. This may happen more than 1 time. In case of multiple collapse events that can be observed by time-lapse technology, the embryos may have a lower implantation potential. So here, collapses 1-2 times. Finally, we can see here normal embryo development, an embryo going from 2 to 4, 8 cells synchronically, no fragments, forming a nice morula, no exclusion of fragments or blastomeres, and then it increases in size, forming a nice blastocyst. Here we see it starts to hatch, trophectoderms going out, and we would grade trophectoderm cells as grade A, and the inner cell mass also grade A. So let's discuss some scenarios. A couple is treated by IVF, 3 oocytes are retrieved, fertilized, and day 5 embryo transfer is planned. On day 5, there is 4 BB blastocyst, 1 BB blastocyst, and then 8 cells grade 1 embryo. So if we should do a single embryo transfer, which one is the most suitable? The Blastocyst 4BB is the most suitable embryo for single embryo transfer in terms of developmental stage and quality. In some clinics, the Blastocyst 1BB would be frozen for a second embryo transfer later. However, it is possible also to culture it, to keep in culture until day 6 and observe whether it will expand. This depends on the protocol on in your own clinic. However, the embryo HL1 is probably arrested at an earlier developmental stage, and we would not either transfer it or freeze it. So this is scenario number 2. A 32-year-old female patient undergoes IVF. 10 oocytes are retrieved and ICSI is selected because of male factor infertility. After denudation, 2 M2 are present, only 2 M2, and 6 M1 and 2 GVs. So what would you do? We would not postpone ICSI for the existing mature oocytes, and we would perform it 4 hours after oocyte retrieval or 40 hours after HCG injection, according to our protocol. However, we would postpone ICSI for the remaining oocytes until extrusion of the first polar body, keeping in mind that if the maturation gets very delayed, more than 2 to 4 hours later, the outcome may be very poor. To conclude, embryo quality depends mainly on gamete quality and culture conditions. The use of an appropriate morphology classification system is necessary to optimize embryo selection. Time-lapse observation and the use of morphokinetic parameters may increase the ability of identifying embryos with the best developmental potential. Thank you for your attention.
And you can connect with our program. We are posting daily our research activities, large number of research articles. You have free access to all these publications that we are offering. We are also sharing our latest research presented at ASRM, which is American Society for Reproductive Medicine, European Society for Human Reproduction, American Urological Association. Also, you can learn about our research opportunities and ART training, which are online ART training and opportunities to collaborate. You just have to find me on LinkedIn, Ashok Agarwal Cleveland Clinic, and you can send a request to join.